Well, good evening, ladies and gentlemen. It's a great pleasure to welcome you this evening to the inaugural lecture to be given by Umesh Kadam. As we always say at these occasions, the inaugural lecture series is very important for the university. I think a very important opportunity to highlight some of the world-leading research that we have in the university. And it is something that many other universities have given up on as a process and as a recognition, which I always think is a great shame. It's also obviously a very important opportunity for the particular person involved. And I know in particular today, Umesh is very, very grateful to see an audience that has come from several different parts of the university, which again I think is a credit to him. But also hopefully as a reflection of some of the things that is good about Keele in terms of different parts of the university working together. So as you see on the screen, Umesh is Professor of Clinical Epidemiology and Health Services Research. He's a GP and he is a Fellow of the UK Faculty of Public Health. He completed his medical training in Birmingham in 1989, and then since joining Keele in 1998 as a general practitioner and part-time research fellow, he's had several different positions, and in 2011 was appointed senior lecturer within the Health Services Research Unit. During the time, he got an MPhil in 1998, an MSc from the London School of Hygiene and Tropical Medicine in 2002, and a PhD from Keele in 2006. As I think we're going to hear, he leads an international research program on multimorbidity, and he's also leading multimorbidity and fragility academic service partnerships with local hospitals, commissioning groups, and public health departments. His current research program is quite wide, and we'll probably be hearing lots about this, but I am going to read it fairly carefully to make sure I get it right. Large-scale general practice consultation and self-report linkage studies investigating chronic disease impacts, using comorbidity and multimorbidity measures based on routinely collected clinical data to target healthcare interventions, developing interventions for patients with chronic disease multimorbidity at healthcare transitions between general practice and hospital-based care, and international collaborations with WHO centres in Sweden to look at how comorbidity develops, and in the Netherlands to compare the healthcare for multimorbidity populations. So in tonight's lecture, I think he's going to show us how healthcare for multiple conditions was first developed as a research program locally. He's going to tell us about the impact of multiple conditions on the quality of life and care of the patient, and on the implications of that for the NHS now and in the future. So we're about to hear now from Professor Umesh Kadam, Adding Quality to Quantity, a Holistic Approach to Healthcare for Multiple Conditions.
Thank you. Thank you. Can you hear me? Great, excellent. Just to add to that bio, in terms of my international history, I originate via Africa, India, and obviously the UK. So thank you for coming to the inaugural. Despite my best efforts to schedule this lecture at Christmas time, obviously you don't have a school play to attend to, and you must have completed your Christmas shopping as well. So thank you for coming. Now, as I was preparing for this lecture, in terms of academic metrics, we say things like world leading and international quality. But I needed to put the context of what we do in the context of the challenges we face. So in global terms, obviously, the desperation of two little boys turning up at the shores of Europe, the tragic and tragedy events in France. So quite clearly there's some global challenges and in a changing world. And most of you will recognize this face, is Andrew Lansley. Despite that smile, the policy that was implemented has resulted in some significant changes to the healthcare structure, which was rewarded with a peerage, and has resulted in a current system in which the NHS is quite clearly facing some challenges. I don't believe the NHS is dying. I think the NHS is worth rescuing. But to do that, we need to address holism in healthcare. So there's been a summary in terms of my biography, but I wanted to illustrate my development in terms of the different locations of care that I have worked in. So the multimorbidity story really began in primary care in 2001, working with colleagues who were interested in musculoskeletal problems. And there I developed the first concepts of multimorbidity and comorbidity. But in the last 4 years, I've refocused, because primary care is important in terms of where the larger population is seen. But people with multiple morbidity often experience acute care. So the program changed its focus to the interface medicine. And here I've developed three overarching themes. The first is around clinical epidemiology. The second is around informatics. And the third is health services research. But any good clinical program or research program has to influence public health and policy. And I hope to illustrate one or two impacts of this program. So in terms of interface medicine and care, which is what the program has focused in the last 4 years, what is clinical epidemiology? So clinical epidemiology is interested in the populations, the different populations the healthcare clinicians see. And there we're interested in the determinants of disease and outcomes over time. Now, in the last 10, 15 years, the critical thing that has developed is electronic information systems. In general practice, every time we see our patients, we clinically code consultations and diagnose them. In hospitals, increasingly the information is collected through computer systems. It seems obvious, but the linkage of this clinical information provides a perspective on the populations that we see and the care that we give them. So the clinical epidemiology program feeds into health services research development. And here, the program has been interested in how primary care populations with a disease go into acute care, so the transitions into care. What happens to those patients in hospital, the hospital care populations, and what happens to the populations when they transition back into the community. So in terms of the clinical focus, or the epidemiological focus, or the public health focus, the program focus has been on the person's experience of 2 or more chronic conditions at the same time, which is multimorbidity. However, the current healthcare system is organized around individual disease care pathways. And in that regard, what we are interested in is how other conditions influence an index condition, which is comorbidity. So even policymakers and Secretary of State for Health are using the term multimorbidity and comorbidity in order to describe the complexity of the care that we face in aging populations. So your question is going to be, why is this program important? Why is it distinctive to anything else that we do? Why should we not just focus on disease care? Well, populations are changing. The demographics are changing. In the UK and the West, there are increasing numbers of older people who are living longer. And as they live longer, they will experience many, many different conditions at the same time. But this is not just a problem of the Western population. In the developing countries, such as India, with increasing middle classes, they are also experiencing multiple chronic conditions. So the populations are changing. People are living longer with more multiple conditions. And yet, in terms of current best quality care, the disease guidelines that we've developed work in silos. So, if you have diabetes, there is a NICE guideline which addresses issues around diagnosis, issues around therapeutic management, issues around the lifestyle changes that a person with diabetes might make. If in addition, on top of that, you have ischemic heart disease, there's an associated guideline for that too. Again, addressing every aspect of a person's care with that problem in terms of detailed guidelines. But then, if the person has osteoarthritis on top of that, there is again recommended care in terms of best model of care. So as you can see, just with these three examples, if a person has all three, the clinicians face the challenge in terms of adhering to all three individual guidelines. The patient has a challenge in terms of self-managing all the three individual diseases, never mind if they have depression, dementia, or any other conditions. The other development in the last 10, 15 years has been around organization or pathways of care. So on this slide, what I have shown is a service map for the single condition of heart failure. You don't need to know the detail of the slide, but to understand the different arrows. So a patient with heart failure pathway can experience any component of the organization care that is designed for the best care. And in effect, those arrows are a ping pong of the care that the patient might face in terms of delivery. That's just for a single care pathway. So if you add other care pathways on top of that, the patient and the carer is faced with a complex organizational system which is fragmented and is actually unsafe. And it's unsafe because if they're engaged in one care but have another problem, that problem might be prioritized differently. So the research program has been organized to answer or begin to answer some of these critical challenges that we face. As I've already said, the electronic linkage of data provides a real opportunity to understand our populations, understand our patients, and how they transition across care. So the program is interested in location of care. The larger general population is catered for by general practice. If you want to understand the multiple conditions that a patient experiences, that is the population in which you will investigate the problem. So through computer records, we can understand multiple diagnoses. Through computer records, we can understand the multiple drugs that are associated with disease treatment. And then through surveys, we can understand quality of life outcomes and linkage to hospital admission data. We can understand transitions into acute care. But as I said, I'm not interested simply in general populations. I'm interested in acute care because in terms of multimorbidity, problems amplify and become a real challenge at the time of acute care. So in terms of that program, I'm interested in the hospital activity. I'm interested in how hospitals diagnose new problems, start new treatments. But the critical focus of outcomes for hospital are around duration of inpatient stay or how many patients they can see through. But to me, the focus is around mortality outcomes, but also quality of life. By understanding the general populations with multiple problems and how they transition into hospital care, we can begin to integrate the outcomes in the general population with hospital activity. And by beginning to do that, we are really facing up to the challenge of how do we deal with the older person with multiple health problems. As I've explained, with multiple diagnoses and multiple drug treatments, with patients who are engaged in multiple care pathways, the problem that's created is around patient safety. So the theme of the program is also focused on patient safety. The single disease guidelines have been excellent in terms of developing specific training models for chronic diseases. But a critical gap in this has been the training of healthcare professionals and patients in understanding multimorbidity. So in that regard, another theme has been around development of a multimorbidity curriculum. So I've set out the context of the question and the scope of the program. But for the next part of the lecture, I want to illustrate 3 studies to highlight the key implications of this program. So I'm going to present some data on study 1. And the question was really around how does comorbidity influence patient health-related quality of life. The healthcare system is very focused on clinical outcomes and in prevention of death. But in understanding the trajectories of multimorbidity, a critical focus should be and has increasingly been on patient-reported outcome measures. Now, although I'm an epidemiologist, for this lecture, I have decided to simplify the data to answer this question. So this was an NIHR study called Comorbidity Cohort Study. And we selected 2 conditions, 2 common conditions, cardiovascular disease and osteoarthritis. Large numbers of general population experience these 2 conditions. And the question was, how do these 2 conditions come together to impact on patient health? As you can see, it was a large-scale study based in general practice population. And the general practice data was linked to patients' self-reported survey measure. And in this case, what we focused in on was shortness of breath limitation. So instead of some complex statistical diagram, I've decided for convenience to simplify and illustrate the findings of the result. So imagine you had 100 people, And obviously, they're all from Staffordshire because they're all smiling. It's the best county in England. And these 100 people are without cardiovascular disease or osteoarthritis. Lucky them. So this is our reference group. But by some chance, one person reports that they have shortness of breath limitation. But now, we have 100 people with osteoarthritis, but this time without any cardiovascular disease. But in this group, we have 10 people who report shortness of breath limitation. And because they're Staffordshire people, despite their OA, they're still smiling because we know the best outcomes are for people who are positive. And so in terms of this result, what we can say is the OA group, in terms of risk, have 10 times the risk of shortness of breath limitation compared to the reference group, everything else being equal. So not explained by any other things. But now we have 100 people with heart failure without osteoarthritis. Now, heart failure is a condition, a chronic disease, where the critical and cardinal symptoms is shortness of breath limitation. In fact, the questionnaire was developed as an outcome measure for heart failure. So it's not surprising that this group, there are 25 people who reported shortness of breath limitation. So 25 times the reference group, everything else being equal. But we know, me working as a general practitioner, is that I'll see patients who have both conditions, heart failure and osteoarthritis. Now, as a clinician and as an epidemiologist, I thought, well, heart failure symptom is characterized by shortness of breath. So the addition of osteoarthritis is not going to change the symptom reporting. But in terms of the study finding, this is the best animation bit of the lecture, by the way. But in terms of the finding, what we found in the 2C study was that 35 times in this group, the relative measure was 35 times the reference group, all things being equal. So osteoarthritis, which is an unrelated condition to heart failure, is not directly connected to it, adds to the heart failure, shortness of breath limitation, all else being equal. So the implication isn't just the more you have, the worse you are. The implication is the more you have, the more likely it's to affect the index disease management. So this was an unexpected finding that the addition of an unrelated comorbidity adds to a specific symptom outcome. So what? Well, in terms of guidelines and in terms of management and in terms of the therapeutic approach, comorbidity requires specific identification and specific intervention. We have quality of care, but this development should be in addition to the quality of care for heart failure and in addition to the quality of care for osteoarthritis. So the 2C framework has been extended to the hospital population through an NIHR-funded doctoral fellowship. And there we are focusing on the heart failure population in acute hospital care to understand how comorbidity influences acute care, but in particular the patient-centered outcomes. Relatively in an acute environment, the population is smaller, but we want to characterize it in detail and follow it up in terms of a 3-month follow-up. And that's a forthcoming study. There has been another study where we've looked at quality of life outcomes for multimorbidity. And in this study, we compared the North Staffordshire population with the Dutch general population. So the question we wanted to ask was, one, how does multimorbidity influence physical health? Two, how does it change with increasing age? And three, how does physical health in North Staffordshire compare with the Netherlands? So in the age group 50 to 59, the dark bars are for the Staffordshire population, and increasing multimorbidity is associated with poor health. But if you get 10 years older, your health becomes poorer. But there's still an independent effect of multimorbidity. So the first thing is to say is, it isn't just an age effect. It's a multimorbidity effect in terms of health getting worse. But the light bars are the Dutch population. So the Dutch population showed the same thing, but for each level of morbidity or multimorbidity, the Dutch were healthier. Well, I know which country I think I want to live in. And as a public health intervention, I need to convince my colleagues that an intervention might be to remove some of our Staffordshire folk to the Netherlands so we can get better health. So study 2, here we wanted to understand transitions in care. And how does multimorbidity influence interface care? So study 2 is the interface study. What is the impact of a chronic lung disease, chronic obstructive pulmonary disease, and heart failure, that combination, on interface care and costs? And this was a study working with CCGs and public health. Here we linked GP registers to A&E hospitals and hospital data for a 3-year time period. So what did we find? So 100 people with chronic lung disease but without heart failure, 43% or 43 out of 100 had not been admitted at least once in the 3 years. So COPD, or chronic lung disease, is associated with high levels of hospital admission. But this is a group without heart failure, but with COPD. But then if you take 100 people with heart failure, but without COPD, only 34 had not been admitted at least once in 3 years. So heart failure as a condition is associated with more hospital admissions. But now, if we take 100 people with both conditions, heart failure and COPD, only 18 had not been admitted at least once in 3 years. People who have chronic lung disease or heart failure will have many other conditions. But what this result shows is that specific conditions of COPD and heart failure is associated with a high risk of hospital admissions. And as part of a broader study, that was the initial data for this group. We also compared other combinations. So at the most extreme end, heart failure and kidney disease were associated with the highest number of admissions, whereas combination of hypertension and diabetes relatively was associated with fewer admissions. But if your question is, well, hang on, hospital admissions might be explained by other things. Well, in terms of our analysis, it was not explained by age, gender, or deprivation. So what are the cost implications of higher number of admissions? Well, in this data, the average costs for hospital per COPD patient without heart failure were £3,000. If you had heart failure, the average costs were £1,000 higher, heart failure without chronic lung disease. But if you had heart failure and chronic lung disease together, your total costs were the highest, which was another £1,000 higher. So the average cost per heart failure and COPD patient were £5,000. So the implications are that the specific combinations, and as clinicians we understand these combinations because through our research we know they're connected, are associated with higher risk of hospital admissions and costs. But your question is again, so what? Well, we have chronic diseases registered in general practice. By using that information, we can indicate multimorbid pathways of care. In terms of risk identification, we can develop measures of stratifying our population by disease and by risk to estimate pathway level of costs. In the current NHS environment, to understand costs becomes critical. And the linkage of information provides the potential for transitions in care, early opportunities for intervention and late intervention opportunities. This study had a national impact in terms of looking at methods of stratification and in methods of cost estimation. So as part of the Year of the Care project, which was a Department of Health project, the real motivation for the health department was to develop cost tariff models for long-term conditions. But this data, I think, was the beginnings of that. But there was heavy interest nationally in terms of this approach. And there was also a webinar series lecture that was given to the NHS improvement community. So the study 3 now focuses on the hospital setting. How does multimorbidity influence discharge planning? In this particular study, the focus is on the qualitative perspectives of patients and carers. So we published a study in which took patients and carers who at the point of discharge, subsequent to that, we interviewed their hospital and discharge experience. So what did the study find? Patients who had chronic lung disease and heart failure were really quite confused because they did not have clarity of information. And they could not understand some of the diagnoses in relation to the symptoms they've had. In a hospital, they experienced a number of medication changes, and the patients reported a real challenge in understanding the multiple drugs that they were on, the new changes that had been made, and the potential side effects that could occur with them. Although this sounds obvious, again, the story was those two conditions together made it difficult to understand what the diagnostic and therapeutic management plans were. And in terms of other findings, the critical issues around acute and multimorbid care are around communication, which is no surprise because that relates to any disease care pathway that we're engaged in. But what the patients did draw out was joined up communication and communication in hospital care that follows through post-discharge. So although they're experiencing acute care, they need to understand how that relates to where they came from and how that changes where things are followed through. This additional qualitative study has been complemented by 3 other papers that we have just published as a multi-center study with Bristol, Oxford, and Keele. From this qualitative studies of healthcare professionals and patients, we begin to understand how organizational management of the heart failure care influences the patient experience. So the heart failure care pathway in Bristol is different to Keele or Staffordshire, and it's different to Oxford. And that influences patient experience. In terms of hospital care, patients were identifying not their consultants as the key coordinators of care, especially in terms of follow-through in the community, but they were identifying the professional group, the specialist nurses, as critical partners in terms of coordinating care. Heart failure is a condition with poor prognosis and high levels of comorbidity, and so it's associated with discussions around end-of-life care. And as healthcare professionals and as a system, we're not very good at having structured and planned discussions around end-of-life care. However, instead of just simply identifying what the problems are and what the challenges were, we took the findings from this result and we worked with healthcare professionals within the hospital, within general practice managers, to devise a potential multimorbid care pathway for people with chronic lung disease and heart failure. And so the discharge planning for that group wasn't just in-hospital care, but it was how discharge is enhanced by pre-admission information and how discharge planning follows through in terms of long-term care. So if we really want to address acute hospital admissions, the high levels of admissions, we need a much more coherent and well-structured pathway which begins before admission and follows through after discharge. And in this framework, we identify critical and practical steps that the general practitioners, hospitals, and post-care might follow. So these three studies illustrate the integration and hopefully the coherence of the programs in terms of multimorbid research, understanding the general populations and quality of life, understanding transitions of care and how that affects costs, and understanding the hospital population and the patient experience in terms of potentially devising new models of care. But the program has also been interested in answering the question, how does multimorbidity begin? The causal study. And how does multimorbidity end, which is frailty and end-of-life care? So in terms of the causal studies, I'm not going to present any data, but working with our Swedish collaborators, we've been trying to answer the question, do chronic diseases share same risk factors? So what we've found is people with cardiovascular disease are much more likely to have an osteoarthritis joint replacement over a 30-year period. As a separate study, we also wanted to investigate a commonly used drug called statins. And the question we wanted to answer was, does a drug for one chronic disease influence the outcome of another? In this case, it was statins use and osteoarthritis. Now, as an academic, the usual metrics that one is interested is in impact story and which journal it might have gone in. Well, the statin publication did make a splash. The Arthritis Foundation in the US was very interested in the founding. And the BMJ Minerva back pages reported the findings. But we had an unexpected impact in terms of front page news of a daily. I have to say, not through my own prompting, and I was slightly disappointed. But I cheered up a little bit more when the study was reported next to Angelina Jolie. So as an impact story, I don't know whether that's referable, but I was pretty happy. I suspect it won't happen again. So the Causal study, as I said, multimorbidity disease management at a certain point in age, it's not about the management of the disease. It's management of the person who's older and frail, who happens to have other diseases. But we wanted to understand the relationship between different types of disease and combinations and frailty. So in the same 2C data, what we have found is different types of cardiovascular disease are associated with different levels of frailty. And as you might expect, heart failure is associated with the highest frailty score. So there's a severity finding in terms of cardiovascular disease. But the condition of osteoarthritis, a musculoskeletal condition, is also associated with frailty compared to the reference group. But if you have the combination of cardiovascular disease and musculoskeletal conditions, there's an additional effect in terms of frailty. So this is an emerging strand in the frailty debate about how does it happen. As I mentioned in terms of the research program framework, we are also interested in patient safety, multiple diseases, multiple pathways, multiple medication. So as part of a NIHR multi-center study working with Nottingham, Manchester, Oxford, Southampton, and Exeter, we have developed a multi-dimensional patient safety toolkit for general practice. It covers system domains. It covers clinical and prescribing safety issues. And we have also developed a patient questionnaire on safety. Now, although this toolkit is being implemented nationally in terms of general practice framework, in terms of the tools we've developed, they are completely relevant to acute care, where arguably patient safety issues, patient safety systems, and patient alert systems are critical in terms of safe care. As I explained earlier, there is a training, relevance, and implication of the program. And we've developed a multimorbidity curriculum which has been nurse-led. And we've developed collaborations with India, Italy, and Sweden. And the questions we asked undergraduate students in these countries was around cases of comorbidity and multimorbidity and how their knowledge and confidence related to potential management of those type of cases. Our overall findings were that students, in terms of the training, don't get training in terms of comorbidity disease management. They might begin to understand it. But in terms of multimorbidity management, where there's multiple problems, the knowledge and training gaps become significant. Now, although this is a nurse-led initiative, the curriculum focus and ambition is really around integrating the training for medical students, pharmacy, and physiotherapy. And this is really important because multimorbidity management is not about a single professional group. It's about the cross-disciplinary and multidisciplinary group engaged in the multimorbid management. So where does the program go from here in terms of ambition and the future? Well, crucially and critically, it depends on partnerships. The program has developed collaborations with public health, and we begin to understand that inequality and deprivation, which are significant in geographical regions such as Stoke-on-Trent, that deprivation is a key determinant of multimorbidity and multiple chronic diseases. But the public health system is under great stress. And I think public health needs to integrate with primary care approaches. I've illustrated how we can use primary care understanding of general populations to understand our multimorbid people and their outcomes. And here, locally, we're fortunate that we have strong academic and service partnerships around primary care. However, the primary care, academia, service, and clinical partners need to integrate with the hospital priorities and policy, hospital priorities and agenda. The program is developed specific hospital-based studies, working with nurses, pharmacists, and different specialties. But there remains a lot to be done here. But good acute hospital care, which is changing, needs to integrate with community and social care. And here, I'm at a loss to wonder or make suggestions until the national funding really addresses social care as a key component of quality of healthcare. But whatever the partnership, whatever the organization, the program cannot be effective without patient and public participation and without multidisciplinary engagement in this topic area. Now, in terms of the research studies, I presented the program findings on behalf of some of the talented students that I've had the privilege of supervising. This list relates really to the last 4 years, and I shan't go through all the names, but some of these study findings around frailty, heart failure, the 2C study, have been underpinned by the excellent work of the talented students that have engaged in the program. So in final summary, currently the quality care agenda is focused on individual diseases rather than the person. There's no problem with that. But in terms of current healthcare systems and the changes that we are facing, in terms of the context of an aging population with multiple chronic problems, we really now need to add quality to quantity. And it's an urgency. And it's urgent to deliver person-centered, holistic, and safe care. But we really need to add quality to quantity as an imperative for our NHS, in which we're facing significantly reduced funding. So that brings to a close the scientific story. But in terms of the program support, I'd like to finish on 3 acknowledgements. The first is to the Faculty of Health in terms of supporting the program and me and Andy Garner. The Health Services Research Unit, so Peter Croft, Claire, Dawn, Lucy, who's now gone to Birmingham, and Dargoy, who supported the heart failure program. The institutes, the research institutes within science and technology and medicine and primary care. And in that regard, particularly Alicia Al-Hajj, and within primary care, Peter Croft, and Rhiannon Hughes, and Elaine Hay. And also the schools of nursing and midwifery, pharmacy, healthcare, health and rehabilitation. In terms of acknowledging the service partners, the program has been privileged to work with Public Health, Zafar Iqbal and John Harvey, Clinical Commissioning Group, both Stoke and North Staffs, Andrew Bartlam and Ruth Chambers, the University Hospital of North Midlands. There are many consultants and many healthcare professionals who have supported the program, and the Midlands and Lancashire Commissioning Support Unit, who is supporting the informatic program and me. And in terms of the academic agenda, I've illustrated the national collaborations, but the international collaborations also include the cardiometabolic group at Lund University, a couple of fantastic heart failure nurses in University of Linköping, collaborators in Amsterdam and Siena. And this program has been funded by Royal Society, MRC, and NIHR. So thank you for listening, and thank you for your attendance.